I'm not going to give a big introduction to the speakers that we have today. They are all very well known. First of all, we'd like to have two very interesting talks on the long-term follow-up in terms of ART. The first talk will be given by Greta Verheyen, coming from UZ Brussels, and she will be talking on long-term follow-up of children after ICSI. After that, Anja Pinborg will be giving us also a presentation on the safety of ART treatments, also in long-term follow-up. I would immediately, to save time, pass the word to Greta Verheyen, who will be talking on the topic of ICSI at this moment. Greta, please go for it.
Thank you, Samuel, for this introduction. And thanks to Eshrey for inviting me to give this presentation. So I have no conflict of interest to declare. So as you all know, ICSI has been developed in our Center of Reproductive Medicine in Brussels in 1991, developed by Gianpiero Palermo. At that time, Dr. Paul de Vrooij and Dr. André van Stertegem were the clinical and scientific directors of our center. Since then, ICSI has been increasingly used, and not only for male factor infertility. And up to now, it's an estimation that more than 5 million children are born after ICSI worldwide, of which 500,000 per year. And it's an estimation that more than 15,000 have been conceived in Brussels. And that ICSI is increasingly used, we see it in this paper from Dyer in 2016, that especially 4 years ago in the Middle East, almost 100% of the IVF cycles are performed with ICSI, which is not the case in Europe, 70%, but we all agree, I think, that we overuse ICSI at this moment. And from the early start, there were some safety concerns, and the question raised whether ICSI is a risky business. Well, we know that ICSI circumvents the natural sperm selection mechanisms, indeed, and that several physiological steps related to fertilization are bypassed by doing ICSI. We also use suboptimal sperm very frequently, immature, amorphous or immotile sperm, and ICSI technique makes it more invasive and aggressive than IVF. And that raises safety concerns regarding neonatal outcome, congenital malformations, inheritance of infertility, metabolic problems probably, disease susceptibility, epigenetic problems, or risk of cancer. That's a lot of questions that have been raised, but of course it's very difficult to separate the treatment-related factors and the possibility of parental factors or the factor related to the parental background. Since the introduction of ICSI, we have invested in UZ Brussels in a longitudinal follow-up study of children, and this was due to the close collaboration of the Center of Medical Genetics led by Dr. Inge Liebaars and the Center of Reproductive Medicine, which was led by Dr. de Vrooij and Dr. van Stertegem. So before starting the ICSI treatment, all parents were asked to give consent for children follow-up, and pregnancy and perinatal data were collected from questionnaires which were sent to parents and gynecologists. So parents were then invited to the Center of Medical Genetics for detailed medical examination of their child at different ages of 2 months, 1 year, 2, 5, 8, 14 years, and more recently the young adults. And this has led to several important publications. So if we shortly first look to the young children, ICSI children compared with spontaneously conceived children, then we see for the very small children, a higher risk of preterm birth, so neonatal outcome, a higher risk of small for gestational age, and a higher risk of congenital malformations, described in several papers, but several other epidemiological studies in different countries showed no increase in congenital malformations, which has been reviewed in the review by Pereira in 2017. So when we look at the 5-year-old children, we see that the results were comparable in terms of cognitive and motor development, neurodevelopment, psychological well-being and growth patterns, but there was an increased cardiometabolic risk and an impaired vascular cardiac function in ICSI children, which was manifested mostly in higher blood pressure. And this has also been described by several authors. When we then go a step further and look to the gonadal development and function, in 8-year-old boys we observed normal penile and testicular growth, normal levels of inhibin B and AMH, and even also at 14 years of age, the development of the genital development, the levels of inhibin and testosterone levels were comparable to the naturally conceived children. For girls, it was observed that they have less advanced breast development at the age of 14. But as well for boys and girls, we saw no increased blood pressure anymore, which was the case in the 8-year-old children. But we saw increased body fat at that age. And then we come to the topic of this presentation, which is the follow-up of young adult ICSI children. So the oldest ICSI offspring has in the meantime reached adulthood, and the oldest ones are 20 years old at this moment. But in Brussels, we started a follow-up study of 18 to 22-year-old singletons, and this has led to a very interesting paper by Belva and has also resulted in the keynote lecture at ESHRE 2018. So the ICSI group of children was defined as the population which was born in 92 to 98 after fresh embryo transfer, only using autologous, only ejaculated sperm. And the majority had been assessed before at different ages in the Center of Medical Genetics. The control group then were peers born after spontaneous conception without stimulation and were mainly recruited at colleges and university. So if we look to the numbers that have been recruited, so the group of genetics detected 423 eligible ICSI families to contact. 303 of them have been reached and 66 families were not interested, while 200 the others from the other families, the young adults, have been approached. These are the numbers of men and women, and actually 47% of men agreed to participate and 60% of women. So this resulted in 55 men and 71 women, which were compared to control peers of men and women. So let's first look to the data of the men, and I go a bit more deeply in these results because they are very interesting and quite unique as well. So this is the important paper of 2016 by Belva, and you see the group of medical genetics and Center of Reproductive Medicine. So let's first look at the male adult characteristics. You see the ICSI and the control groups are quite comparable except for a small difference in age, which was significantly different, but weight, height, BMI, smoking, behavior, alcohol use, sports were comparable, as well as BMI of mother and father and the birth weight for the children. Both groups had comparable rates of genital malformations, so 14% in ICSI and 11% in the controls groups. Comparable testicular volume, 16 versus 15.3 milliliters in the controls. So this completely comparable. So when we go to the hormones, the gonadal function, testosterone was comparable. You see here the median values, and between brackets you see the interquartile range. And you see no difference in testosterone levels in these young adults. The median values of FSH were also comparable, but when you focus on the more than 90th percentile, so the 10% of highest values, then you see that you have more ICSI adults, ICSI men with high FSH levels than the controls, which is significantly different, but not any longer different when you adjust for confounders. You see that indeed there are 3 times more boys or men with high FSH compared to the controls. LH was comparable. Inhibin B median values were comparable, interquartile range, but here as well we have, when we look to the less than 10th percentile, then we have a tendency to have more men with low inhibin B compared to the control group, but this was not significantly different. This tendency to lower inhibin B levels is recently confirmed in a paper by Sontag this year. So if you then look to semen quality values, we see indeed that the concentration of ICSI boys was significantly lower than the control population. And the concentration was half of the controls. Also, the total motile count was very significantly different, but progressive motility was comparable. But due to the lower count, we see that the total motile count is also significantly lower, 3 times lower than the total motile count in the control population. When we consider these values of semen analysis and we compare them to the reference values according to WHO 2010, first, let's look at the concentration below the reference value of 50 million per ml. Then we see that 43% of ICSI boys versus 21% of the controls have values below this level. This means that ICSI boys are 3 times more likely, as you see here, to have concentrations below that reference level. When you look to severe oligozoospermia, we didn't see a difference because, you see that the numbers are quite small. Also, progressive motility, normal morphology were not different, but total motile count, again, we see here that ICSI boys are 4 times more likely to have a total count below the reference value compared to the controls. So these are the values in red. Let's look to the respective fathers, because this is also an interesting finding. And here you have the median values for the respective fathers of these 54 boys. They had a median concentration of 5.7, while their sons, the median concentration was 17. The total count was half in the fathers compared to the sons, and the total motile count was also much lower than in their sons. When you look to the number of fathers with concentrations below the reference value, it was 72% against 43% of the sons. And severe oligozoospermia, 48 versus 15, and total motile count, 70% of the fathers had below values compared to 54% of the sons. Of course, in the early era of ICSI, it were mainly male indications for ICSI, and which is different nowadays. When we look to correlations of semen, of quality of fathers and sons, and this is quite interesting, we see that there is no correlation between the concentration, progressive motility and total motile count of the father and the respective sons. And this is maybe a bit surprising. And paternal total sperm count was even negatively correlated with the total sperm count in the sons. If you look to the fathers, only 40% of fathers with total sperm count of below the reference value had sons with sperm counts below this reference value. And that's also what you may not have been expected. ICSI young adults were also not more likely to have sperm concentrations below the reference value if their fathers had this low sperm concentrations. So this is quite interesting to know. Then we can take a look at the women. So we compare them with the controls, and we see that the studied parameters as AMH, FSH, LH, E2, DH, EH, and antral follicle count were all comparable between or similar between ICSI women and their control peers. Only when you only consider the ICSI women taking contraceptives, then their E2 levels were higher compared to their control peers. What about their metabolic parameters? They're almost all young adults were also studied for these parameters. The characteristics, weight, height, and BMI were comparable, and even after adjustment for confounders, as listed here, the results were still comparable in both groups. There were also no differences in total cholesterol and LDL cholesterol between the two groups, but we saw a lower HDL cholesterol in ICSI men, but not in ICSI women compared to their controls. Although you see that the values are not, they are significant, but not that highly different. Other parameters of the metabolic syndrome were also comparable between ICSI and their control adults, as you see here listed on this slide. About body fat, so ICSI men showed higher peripheral fat deposition, hip circumference, than their controls. And this is the difference that you see here. But all other parameters were comparable between ICSI adults and their control peers, as specified in skin fold thickness, waist circumference, whole body fat distribution, and cytokine levels, leptin and adiponectin. So what about other literature? Because what I showed up to now are all studies collected, or study parameters collected and published in our own centers, as we invested a lot in follow-up, especially the Center of Medical Genetics. But what about other literature on follow-up of ICSI children at adult age? Well, papers on long-term follow-up of specific ICSI children, adults, are very scarce. And many papers, we have indeed many papers on ICSI children, but they mostly compare ART, so the whole population together, versus non-ART, or they compared a combination of IVF ICSI babies with naturally conceived babies or higher age of children. We have a few very good reviews, and I will focus on the one of Catford. And we have a few recent papers also published. So if we go to Catford, and he indeed also compared ICSI children with their spontaneously conceived offspring as controls, and he did a review. His search yielded a few thousand papers, of which only 48 were satisfied and of reasonable quality. But as they were not all as good, he categorized them as poor, fair, or good. But these 48 have been studied and compared only ICSI with spontaneously conceived offspring. In general, data are not always conclusive, because you see here on some parameters as neurodevelopment, there were 24 studies, overall reassuring, except for 7 who mentioned problems in terms of neurodevelopment. General physical health, there were 6 studies, but without agreement in these studies. Metabolic health, 5 studies, but some of them mention increased adiposity. And vision and hearing, there was one study that mentioned abnormal retinal vascularization. Data were conclusive regarding growth, 3 studies with the consensus that there is no difference. And they were also conclusive regarding reproductive health. Overall, reproductive health is reassuring, but there is a tendency to decrease semen quality, which needs further follow-up. A more recent paper from April this year, Sontag et al., I summarized the results of this study. It's actually a German study, and the data were collected from 7 different German registries, so it was not a single center study. And these children were born in 1999 and 2000, also ICSI versus spontaneously conceived offspring. Their sample size is higher than the one that we had in our hospital here, but of course they collected from 7 different registries. This study largely confirms the findings of the Brussels investigators. Let's say in the male, higher weight, BMI, waist and hip circumference, and higher overweight ratio. So these are things that we also observed more or less the same. Similar pubertal development in both groups. Lower inhibin B levels, higher E2 levels, lower testosterone to A2 ratio may indicate altered testicular function, but this is also a conclusion that we could make. In the female then, higher overweight ratio, but similar pubertal development, hormone levels and age of start of menarche. What are now the limitations regarding follow-up studies? And indeed, there are some limitations. There may be many potential confounders, and data are not always adjusted for it when we look through the different papers. And of course, varying quality of studies, they limit the ability to give definitive conclusions regarding follow-up at adult age. Of course, it's quite difficult to run follow-up studies. For many parents, it's still a taboo and they don't want to participate in the study. It's difficult to find funding. It's very labor-intensive. And of course, we are confronted also with the GDPR, which makes our lives also more difficult. And moreover, it's difficult to recruit matched controls, and they should be reliable controls. Then we have selection and participation bias, because we don't know whether those that agree to participate, whether they are representative for the whole ICSI population. And of course, so far, the cohorts of children and adults are too small to draw definitive conclusions. We also know that ICSI for male indication is maybe very difficult, very different in terms of follow-up compared to ICSI for non-male indications. So we have also to take this into account and very well specify our populations. And so far, it's very difficult to separate the effects of the ICSI technique itself and the effects of the underlying paternal and maternal factors. So that's another difficulty. Moreover, we may have variations over time and between countries. So then I come to the conclusions of the presentation. So globally, the available data provide reassuring evidence regarding reproductive health and in general health of ICSI children. The available studies on adult ICSI men and women are so far small populations, and only ICSI with ejaculated sperm has been, children derived from ICSI with ejaculated sperm have been studied. In ICSI men, there is a trend to higher FSH and lower inhibin levels, tendency or lower semen quality compared to the controls, and maybe we have to be concerned about transgenerational inheritance, although the fathers and the characteristics of the ICSI fathers were not predictive for the quality of the semen of the sons. But anyway, consequences for reproductive success of the sons are so far unclear, and we need further follow-up to test this. In ICSI women, data are reassuring, and this is not really surprising, as so far the majority of studied ICSI women were conceived after ICSI for male infertility and not for female infertility, which is coming maybe later. So future directions then, we need larger cohorts of ICSI adults to be studied for follow-up, as well for male and non-male infertility. We should try to separate the effect of the ICSI technique and the underlying subfertility of the parents. We need to further explore the transgenerational inheritance of subfertility. We need to study also other subgroups, and we started now the follow-up of ICSI boys born after ICSI for non-obstructive azoospermia, which is even much more difficult than those with ejaculated sperm because the group is much smaller. We need to follow up further at higher age in reproduction. Are they fertile? Do they have the same fertility problems as their parents? And even post-reproductive age, we need to do or continue the follow-up. Epigenetic modification is still a question mark, and we need to follow up if there is a higher risk of cancer in ICSI adults. So finally, I would like to thank the colleagues of the Center of Medical Genetics, and I specified those persons or collaborators who have invested a lot of work to do this follow-up, and thanks to them we have these data available. And also I thank the present and past colleagues of the Center of Reproductive Medicine, and of course all of you for listening to my presentation. Thank you.
Thank you very much for your very interesting talk, Greta. Very eye-opening to have a history of so many years of how things have been developing in the field of ICSI. I also would like to remind all those that are participating that the Q&A session will be held at the end. And if you will notice in your form, there is the possibility to answer or have ask questions directly using the GoToWebinar app. And please send in all the questions that you would like. If you already want to start holding the questions, you're happy to do it. And I will then be filtering and giving as quick as possible and as many questions as I can to the speakers. At this moment, it is now the presentation of Anja that I would like to perform. I'm going to ask her to kindly switch on her camera while Greta switches off hers and her microphone as well. And the talk that will now be done by Anja Pinborg is on long-term safety of ART treatments. Please, Anja, the floor is yours.
Thank you, Santos, for this kind introduction, and thank you to the ESRA and to the SIG Quality and Safety for inviting me to give this lecture. It's my big pleasure to talk about the subject that has interested me for the last 20 years. I just need to move my camera a little bit so that I can see the slides. Yes, let's go to the long-term safety of ART treatments in women and offspring. And as the previous speaker has so well and excellent went us through the literature on ICSI, I will not go very much into details about ICSI children. Yes, I have a little problem with changing the slides.
We'll try and check it now to see if we can make it work. Otherwise, we will do it ourselves. Do you want to give it a try now, Anja? I think it is now working.
It seems not to be working. Is it because, just a moment, I just try again.
Okay.
Yeah, now it's working. Sorry for this. I don't know what happened. Yeah, and here are my conflicts of interests. The learning goals of today is to address long-term health risk of ART in women and offspring. I will go into detail about neuropsychiatric morbidity, cardiovascular morbidity in the children, and also malignancies in the children. And then I will touch briefly about the long-term health risk of the women, and that is, of course, the malignancies. But that could be a full presentation on itself, so it would just be a brief presentation on this. So the long-term health of children, I think the good story is that most children after IVF and ICSI are completely healthy and are looking very much like the background population. More than 8 million children, or maybe more, have been born after assisted reproductive technologies worldwide. According to the IEM data published in Human Reproduction Open this year, 0.2 to 6.6% of the European birth cohorts are born after ART. And Denmark is one of the countries lying highest on this rate of ART children in the birth cohort. So we really have an obligation here to follow the children. This is the figures from the Nordic data on multiple birth rate, and I show it to really depict that a country like Sweden, who already in 2007, as you can see here on the slide, had lowered their multiple birth rate to 5%, also showed on the other side here, preterm birth rate, that they had a significant decrease in preterm birth during the same years. So by declining. So by a decline in multiple birth rate, we can really adjust the preterm birth rate to levels which are like the singletons in the background population. That, I think, is one of the most important messages of this talk. In this, you see the updated from the Conatus cohort. You can see here clearly an increase in the number of children born after assisted reproduction, while the multiple birth rate have gone down until 2015 and is continuously decreasing. In all the Nordic countries now is the multiple birth rate less than 5%, like also I know in Belgium and Holland and other European countries. But you see, as also we heard in the previous talk, that the children born after ICSI are actually decreasing, and in some countries more than 90%. In the Nordic countries, they're lingering about 50% of the birth cohort. But another interesting finding is that the children born after cryopreservation has steadily increased during the last 20 years. And with vivification and blastocyst transfer, we now will see in the future very high proportion of children being born after cryopreservation of embryos. Let's have a look at this slide. This is a slide that has not been published yet, but is a slide of the cerebral palsy rate in the Nordic countries from the beginning of the IVF era in 1995 up to 2010. And you see that there has been a half rate of cerebral palsy in the ART population from 0.83 to 0.25. And this is, together with the lower preterm birth rate, the most important and significant improvement in the health of ART children. So by lowering the preterm birth rate, we can lower the most severe disability in ART children, and that is cerebral palsy. I think for parents, it's one of the worst disabilities, and they would really avoid that. So by doing single embryo transfer, we actually do the best for the children that are born after ART. No more talk about multiples. Now it's about academic performance in ART children. And here you see a national register study on ART singletons, non-ART singletons, and ART twins in the Danish population. It was published in Human Reproduction in 2017 and showed that I have to explain that all Danish pupils are taking the same exam after 9th grade of school. So they are around 15 to 16 years. And we see here that the mean scores are actually equal, are actually slightly higher in the crude mean test scores compared with the non-ART singleton population, but similar to ART twins. But when we correct for the most important confounder in this, which is maternal education, which is of course higher in the ART population because they wait further, those with high academic degrees wait longer to get pregnant, and therefore in the ART population there will be more women with a high educational level. So by correcting or adjusting for educational level, we see a slight decrease in the mean difference in school performance. The same was shown in this study in the Swedish population with more than 8,000 Swedish children, slightly higher mean test scores, but after correcting for educational level, this is balancing out and there is a slight lower mean test score in the ART children. So regarding academic performance, we can see that ART singletons had higher crude mean test scores, but after adjusting the mean test scores was slightly lower, but without any clinical significance as it's only 0.15. Similar results in the Swedish population. Singletons born after fresh and frozen embryos had similar mean test scores. We showed that in a publication in BJOG in 2018. And then IVF and ICSI singletons had similar performance in school grades at the 9th grade, which is actually very much aligning the results in the previous talk. And similar school performance was also seen in ART singletons and twins, but what we saw in the twin population was that fewer of the children actually passed the 9th grade exam. It was a fewer percentage difference between singletons. It was more than 95% in the singleton population who passed this exam, while it was a little less in the twin population, indicating that there might be a higher number of disabled children not aiming to take the 9th grade exam. Another question which is often raised when it comes to long-term health in ART children is autism and mental retardation. And here's from a Swedish register study figures on autistic disorder and mental retardation. And what they found is that there was no significant increased risk of autism in ART compared to non-ART children. For mental retardation, they found a slightly increased risk, but that it was leveled out after adjusting and after only including singletons. So this is related to the multiple birth. So for singletons, no increased risk of autistic disorder or mental retardation. The same was actually shown in this huge Massachusetts cohorts of 10,000 ART children and 8,000 born of subfertile mothers who did not have ART but took more than 1 year to conceive. And here you see for the autism spectrum disorders that the similar risk in ART versus children born of fertile women, in children born of subfertile versus fertile women, in IVF versus fertile, and in ICSI versus fertile. So in this also severe disorder, there was no increased risk in the Massachusetts cohorts. Similar also in this meta-analysis made on autism in this from this Chinese author group, no increased risk of autism spectrum disorders when adjusted for multiplicity. So it lies on the multiple birth. Another Danish study looked at fertility treatment and risk of childhood and adolescent mental disorders, and it's a full register-based study. They looked at children born after ovulation induction, only fertility drugs, or insemination treatments, on IVF treatments, and on ICSI children. And what they found when they looked at psychiatric diagnosis, they found only in the IUI or ovulation induction population an increased risk, similar with disorders of psychological development and behavior and emotional disorders. And this indicates to me that this is a question, not that IUI causes psychiatric disorders or developmental disorders, but it's the background population who have disorders, for example, endocrine disorders and other disorders of anovulatory infertility, PCOS, are in this group. So it had nothing to do with the invasive procedures like IVF or ICSI, where the figures or the risk of psychiatric disorders were exactly the same as in the background population. Now let me turn to childhood cancer. This has also been examined in quite many studies now, and in particular during the recent 5 years, a number of large-scale studies have popped up on this, and they are all very reassuring. This was one of the first large cohort studies from the Nordic Conatus group, where we showed that there was no increased risk of cancer, of any cancer, in the children born. There were some sub-diagnoses where we found an increased risk, but taking together, this may be random findings because the sample size is too small. Then we were down to very few cases. So overall, no increased risk of cancer in the Nordic children. This is then a UK study, and they found the same, no increased risk of any cancers taken altogether in IVF versus non-IVF children. You see here the standardized incidence ratio was 0.98. But when they looked into specific diagnosis codes, and you see here it was only based on 6 cases and 10 cases for rhabdomyosarcoma, they found for 2 cancer diagnoses an increased risk. But this is always the difficulties you have when you have very few cases, that if you go into very rare sub-diagnosis, you will by chance find some diagnosis. And in this study, they found no increased risk in children born after frozen and fresh embryo transfer. A very nice study from the Dutch Omega cohort by Span and Floor van Leuven in Human Reproduction 2019 found the same. Overall cancer risk was not associated to ART-conceived children. They also included a subfertile cohort, children born to subfertile women, and in this case they found a hazard ratio of 1 in ART versus children born of subfertile women. They also looked at ART versus the general population and found similar results as ours in the Nordic cohort, a 1.1 in not significant risk of childhood cancer. They also looked at ICSI, no significant increased risk, and cryopreservation. They found 1.8, but that was not significant, and with a high confidence interval. In 2019, a study was published from another Danish group in JAMA, where they found that the overall message of this publication is that no statistical significant association was found between use of any fertility treatment, any fertility drug, IVF or ICSI, and cancer in children. However, they found by doing multiple sub-analysis that children born after frozen versus women in fertile women had an increased cancer risk of 2.43. But this finding was again based on 14 cancer cases in 18 years. So I think we should look at the other 3 studies not finding any increased risk in frozen embryo transfer. And this was mainly driven by an increased risk of leukemia and sympathetic nervous system tumors. This group also in 2015 published another study where they found that it was progesterone which was causing a high risk of childhood cancer in ART children. This was not found in this study where the risk of cancer was not increased in children with women having lots of cycles with progesterone. So I think we still need to confirm the results in frozen embryo transfer children in much higher scale studies. Then we go to cardiovascular function and metabolism, and we have shown that there is a higher risk of being born large for gestational age after cryopreservation of embryos, while there is a lower risk in children born after fresh embryo transfer, who on the other hand has a higher risk of being small for gestational age. We know from studies outside the ART literature that LGA, or large for gestational age, and small for gestational age can give rise to obesity and low insulin sensitivity and also metabolic disease. So is there a relation between the large for gestational age and a long-term health risk in children from frozen embryo transfer? A very reassuring study from Halliday in Fertility and Sterility in 2018 looked at a population of 192 ART versus 86 non-ART children, all aged between 22 and 35 years. And they did very thorough interviews, questionnaires, and physical examinations. And in this cohort, they didn't find an increased risk of vascular and cardiometabolic risk, and growth and respiratory problems were not higher or not different in the ART population. So quite reassuring in this older cohort of ART adults, young adults. This paper from Scheer in 2012 was also mentioned by the previous speaker. It found that there was a vascular dysfunction in the systemic and pulmonary system or circulation in ART children compared to the controls. They did a follow-up study which was published in 2018, and there they found that there was an increased risk of high systolic blood pressure and high diastolic blood pressure, and they found in 8 out of 52 ART children that they fulfilled the criteria for hypertension. And they also found that flow-mediated dilation was lower, intima media thickness was higher, and pulse rate velocity was higher in the ART group, all indicators of a less adaptive cardiovascular system in the children born after ART, which might lead to higher risk of cardiovascular morbidity in their later life. But we don't know that yet, and it's, again, very small studies. A larger study on blood pressure in ART children showed that in the younger cohorts born before 2000 or year 2000, there was an increased risk of high blood pressure, both systolic and diastolic, while in the younger cohorts born after year 2000, there was a similar systolic and diastolic blood pressure. Overall, they had, if they pooled these two cohorts of the younger and older cohorts, they found an increased mean systolic and diastolic blood pressure. But it seems maybe that this has balanced out in the younger cohorts of children. So actually, regarding cardiovascular health, I think a lot of questions still remain, and we can't say anything firmly regarding the health risk on the long run of ART children. But what we can look into is there some differences, for example, in the frozen cycles? And what has been published in several papers during the last year was regarding program cycle. The program cycle is a cycle where we use, it's also called artificial or substituted frozen cycle, where we use estradiol and progesterone to create an artificial menstrual cycle. And in these pregnancies compared to natural frozen cycles where there is actually an ovulation happening in the woman, there we see that the program cycles with no corpus luteum and no ovulation, we see high risk of hypertensive disorders, high risk of postpartum.
but nonetheless, there's still a lot of questions that came in. So if it would be okay with you, I would like to extend this talk 5 to 10 minutes over its time so that we can have the opportunity to at least reply some of the questions. If some of the other questions that come in are later not replied, we promise that over the next days we will try to have a written response via the website of ESHRE. So the first question that we have is directed to Greta, coming from Mariana D'Angelo, which is a very pragmatic question to Greta, which is, has any of the ICSI adults from the cohort that you had children already? Yeah.
No.
I think the microphone is...
Yeah. So it's of course a very interesting question, but these women and men were so far too young to have children. So they were between 18 and 22, so it could have happened that there were already children, but so far we were not able to really test their reproductive success. And this is of course a very important point for the future.
Yeah, thank you. And to Anja as well, or now to Anja this time, the question would be, would you recommend low-dose aspirin in frozen embryo transfer cycles with HRT to reduce the risk of pregnancy-induced hypertension and preeclampsia?
Yeah, that's a very good question. Actually, I think we have included it in our oocyte donation guidelines. So in oocyte donation pregnancies, we are now discussing also to include it in the frozen embryo transfers. But I think what has been at least been recommended from the Danish Society of Obstetrics and Gynecology is that the risk should be more than twofold increased, and we have not found a more than twofold increased risk of preeclampsia and hypertensive disorders. So, but it's definitely a discussion worth, and I think it should be very loose, or it should be you should be quick on giving it if you can see that there has been preeclampsia before, or if there is a blood pressure which is actually quite high. So I cannot say that we are doing it now according to our guidelines, but we might look at it once more.
Okay, thank you very much. Now, directed to Greta, a question from John Ekwani, which is, thank you for your educative presentation. I have a question regarding the uniformity of the semen analysis. And basically the question is, considering that you used the 2010 WHO standards for semen analysis, would you have had the same standard between the fathers of ICSI and those sons that are now in adult age? So was there a difference, or there is expected difference due to different criteria being used?
Well, that's indeed a very good question, because the 2010 criteria are of course before the birth of, so the young adults now, the criteria have been changed for them according to the fathers, but I can say that the reference values, or at that time it were considered normal values, now it are reference values, they have changed, but the way we perform our semen analysis has not changed. So we already applied the strict criteria in that period of time because they are already quite old, and we already performed them since the 90s, I guess. I don't know exactly which year. So the way we perform the semen analysis has not changed. But it's indeed a very, very good question. Yeah.
Okay. Thank you for the answer.
That have been changed. Yeah. So they always lowered the reference or the normal values, now reference values, but we didn't change the way of proceduring the semen analysis. Yeah.
Makes complete sense. Thanks. Now from Sarah Velveva, really close to you, Anja, and thanking you for the lecture. But the question was, as IVF children follow-up reveals reassuring results, do you think that at this moment, when IVF origin will no longer matter anymore? So basically, do you believe that as things increase and become more and more reassuring, do you believe there will be a time in which we no longer need to be concerned about this issue?
That would be when I go on pension, but no, I think we should be curious about this still some years. And I think before we have the long-term health risk, before we have adults that are 50, 60 years where we can see if there is any changes, for example, in cardiometabolic health risk and also in their way of their reproductive health, which is also very scarcely examined. I think there's still a lot of research that should be done. And I think we should keep the interest in the new method that we are introducing, and for example look very much into detail about the program frozen embryo transfer cycles, because I think it's why should we do all these pregnancies without a corpus luteum now when we know that so important hormones are produced there. So I think there's still a lot of research to be done.
So I gave you an easy question. I'm going to give you immediately a more difficult one. Coming from Dunja Bastenbust, do you think that the new one-step media and the use of epoxy during embryo culture will decrease the possible cardiovascular effects and health aspects of the children?
That was a very challenging question for a clinician as I am.
Yeah.
So
I don't know if you have any thoughts on this, Greta.
I think we should keep a close eye on everything that we do, like we have done with vitification. We should also include medias in the close eye look at the children. So I can't say it now, but I think every step we take to change things and optimize things can have an influence on the outcome.
I fully agree, but we have always a lot of confounding factors, and this will always be a difficulty. But I agree that for the next generations behind us, that we still have that they still have to continue the follow-up studies. Very important. Yeah.
And now a question from Willem Verpoest, which is directed to actually both speakers, which is a paper from Belva recently published from the group of the VUB, showed an increased risk of chromosomal abnormalities in the ICSI children related to sperm count of the father. Do you have any mechanism which could explain this increased prevalence of chromosomal abnormalities? Is it biological? Is it something that's iatrogenic? Greta, do you have any thoughts on this topic?
Yeah, that's very difficult to say, of course. Wait, can you repeat the first part?
So the question came from the work of Belva, showing that there were increased rates of chromosomal abnormalities in the ICSI children related to the sperm counts of the father. And the question is, do you have any idea of the possible mechanism around it?
Well, we know that there is a paternal influence, of course, and that at the moment of, when the embryo takes over at genomic activation, that paternal influence also plays a role, which is manifested in the quality of the embryo. So, we have to control if we have a high rate of, indeed, chromosomal anomalies, which are maybe mainly due then to mitotic errors. And I think the group is too small to draw definitive conclusions on that. But the paternal influence is something indeed which is very important to continue studies on.
Anja, I don't know if you'd like to add anything on that, and I would also at the same time like to give you another question that was asked, which is, has there been any suggestion of a slight increase of Hodgkin's lymphoma after ART to your knowledge?
The first question, I fully agree with Greta that it might be some chromosomal instability in the sperm chromosome that causes chromosomal aberrations in the children. And I think we have just made a meta-analysis or tried to make a meta-analysis on chromosomal aberrations in ICSI, and it's very difficult because the studies of are so heterogeneous, and the control groups, it's almost an impossible study to do. But what is, I think it is related to, is to the sperm quality and not to the ICSI procedures itself. And the way we have seen that chromosomal aberration in ICSI children have actually decreased over time shows us that it's not the ICSI procedures. It might more be to the population, because the population is diluted now with a lot of other diagnoses than male factor infertility. So the really severe cases of male factor infertility are diluted now. And that's why we are seeing a decline in chromosomal aberrations in ICSI children. So of course it would also be better to do the ICSI procedure now that we are not harming the chromosome so much that we did in the beginning. I'm not an embryologist, and to the other question, I would say that Hodgkin lymphoma, no, I've been through the largest studies now, because I had to give another presentation today on cancer in ART children. And all studies has a certain diagnosis that is increased, because all studies are looking into sub-analysis and sub-diagnosis of cancer. And in all studies they can find, in one study it's rhabdomyosarcoma, in another it's leukemia, in another it's lymphoma, in another it's hepatoblastoma and rhabdomyosarcoma. So every study has its increased specific diagnosis, but it seems that there's no real pattern in this. So I think more or less of these very specific diagnoses that are increased are more related to random findings due to multiple comparisons.
Okay, thanks. So I would give an opportunity to a final question. There are still quite some questions that are here, but we will need, unfortunately, to close, and we will then afterwards have the opportunity to respond to some of them in written order. And the final question goes to Greta, which is, would you speculate whether the potentially now picked up effects will diminish over time as we do better or further developed ICSI techniques in later birth cohorts? So the question is, do you believe that we are getting better at ICSI and improving it in a way that these sort of effects will decrease?
And which effects? Because I didn't understand very well what you said.
So the overall potential negative effects on the newborns, do you believe that ICSI itself has changed over time, and our experience of ICSI over time has changed in a way that it might diminish the negative effects that we're seeing?
First of all, it's important to discriminate if the effects that we see are really due to the ICSI procedure, because that's what we don't know so far. And how can we compare this? Well, if we have more and more young adults now which are coming from ICSI, not for male infertility, but for female infertilities, because we use ICSI more and more. So maybe there we can, the effect of ICSI, we can, for example, compare IVF children and ICSI children for both tubal infertility, and see whether there is an effect of the ICSI technique. So I think this is a very interesting populations to compare, IVF and ICSI children for the same indication of female infertility. And it's maybe the only way to check whether there is an effect of the ICSI technique itself, because that's a question which has not been answered so far, if you agree with me.
Yeah, no, it makes sense. It makes complete sense. So
I think improving the ICSI technique is still what it is. So we do it still the same way as we did it before. And we have to rely maybe on companies to develop automatic ICSI or something like that to standardize it. But ICSI is ICSI, so you inject...
So you don't believe it will change?
I don't think so. But we don't have the answer. Yeah.
Thank you very much for the participation of both of you. I believe that now it is the time for us to close the session. It was very, very positive. I still have now the questions coming in, still quite a lot of them coming in. We will try and filter them and try and condense the ones that are more similar to each other, because we do have some of those. And if there's the opportunity to have a short response that we can then publish, then that would be great. I would like to again thank to both Greta and Anja for their availability, and also to the Estre group of staying so late to be able to organize this webinar, which we're very happy about, and the success that it came out, and to the huge participation that we had with all these attendees that have just and that are still connected. Thank you very much, and I hope you all